Hello everyone, and welcome to our weekly podcast brought to you by VJOncology. This week, we will be covering our highlights in gastrointestinal cancers from the ASCO 2026 meeting, which we attended live in Chicago. First off, Ghassan Abou-Alfa from the Memorial Sloan Kettering Cancer Center presents efficacy and safety results from the Phase 3 EMERALD-3 trial, which assessed stride with or without nivolumab compared with TACE in patients with unresectable embolization-eligible hepatocellular carcinoma.
The GI oncology has been really very big this year at ASCO, and I really was greatly honored on behalf of all my co-authors to present on the EMERALD-3 study. As we all know, chemoembolization or transarterial chemoembolization, or what we call TACE, is a standard care therapy for intermediate stage disease. The question is, can we really make it better? Can we enhance the survival or progression-free survival, which sadly at the moment is only about 8 to 10 months? And yes, we can. If anything, we have been attempting to do this because, as we all know, when you do chemoembolization, you enhance certain cancer antigens, which of course will induce some of the immune checkpoints. And this is a great opportunity to add on the checkpoint inhibitors to really enhance on the activity. And for that reason, for the TACE, we added on durvalumab as anti-PD-L1. We added to this also an enhancer of this activity, being anti-VEGF, being lenvatinib. And also, on top of the chain of command, we looked at anti-CTLA-4 with the tremelimumab. So as such, the study was combined of a triplet, the tremelimumab plus durvalumab plus TACE, and the lenvatinib, and also an arm B, which was the tremelimumab plus durvalumab plus the TACE, and the third one was TACE only. We did compare for arm A, which is the stride, which is tremelimumab plus durvalumab, we call it together stride, plus lenvatinib plus TACE, we compared it to TACE alone. And then we did also look at PFS as primary endpoint. Why PFS? It's a local advanced disease, prolonged survival. At the same time, we really care about what's happening local, and we compare that. And then ultimately, we carried on to look at the OS, and then we did the same thing for arm B, stride TACE compared to TACE, PFS and OS. What did we find out? Interestingly, we found out that the outcome was positive no matter how you look at it. It was statistically significant for an improvement in regard to the progression-free survival, 13 months for the stride lenvatinib TACE compared to about 9 months for the TACE. It was also the same thing, a trend of positivity in regard to the stride plus TACE, about 13 months compared to 9 as well. In regard to survival, by all means, it was also a trend of positive outcome, 39 months compared to 34 for stride lenvatinib plus TACE. But impressively, when it came to arm B versus C, we saw a non-calculable yet, not even achievable yet, median survival for the stride plus TACE compared to about 34 months for the TACE itself. So where do you go for this? So no doubt about it, these drugs are adding on to the value of the TACE. By all means, because they're all available, could we consider that we're going to use those intervention, adding them onto TACE? By all means, we will. And this is what we're going to apply as early as tomorrow morning. A nice question that was asked, and you recall, it was like what about comparing arm A to B? Because in other words, how much lenvatinib is adding on? And yes, I do agree with all the comments that were given. Really, the lenvatinib did not add much. Maybe a small exception of the patient from Japan were non-viral. There was some add-on value for the lenvatinib, but for the general population, anywhere in the world, stride plus TACE appear to be the right therapy.
Following on, Yelena Janjigian from the Memorial Sloan Kettering Cancer Center comments on the RASolute Field 2 trial in pancreatic cancer and the emergence of EGFR HER3 bispecifics for gastric cancer.
We saw a lot of interesting data from China for EGFR HER3 bispecific in later lines setting. We're also seeing very interesting data, of course, in HER2 space, in colorectal cancer we saw. And what's interesting is a lot of the assets are coming from Asia, from China, and we need to be aware of this data. And some of it may be directly translatable to our patients. In some cases, we may need to do additional studies for confirmation. But the plenary was inspiring, and I think all of the space now is reinvigorated and very hopeful because, of course, we are successfully targeted and overcame treatment barriers in pancreas cancer, which is for RAS mutant tumors. And so we're interested in looking for RAS targeting across tumor types, including gastric, of course, colorectal cancer, where it's very promising.
She also highlights safety results from the DESTINY-Gastric-03 trial of first-line trastuzumab deruxtecan-based combination regimens in HER2-positive upper gastrointestinal cancers and its emerging role in this setting.
We presented the DESTINY-Gastric-03 study, which is a phase 2 study looking at T-DXd-based combinations in first-line setting in HER2-positive disease, and the safety analysis from the low-dose and high-dose T-DXd arms. And what we demonstrated is the combination of capecitabine plus T-DXd at 5.4 mg per kg with pembrolizumab was safe and effective. Why do we do this? Well, of course, antibody-drug conjugates revolutionized how we treat gastric cancer in later lines therapy. Bringing it to first-line therapy is so important, but in order to do that, we have to combine them safely with fluoropyrimidine, and we were able to do that. The grade 3/4 toxicity rate was acceptable compared to what we would normally expect in this setting, in first-line setting. And now this regimen and the efficacy was very promising. We saw nearly 100% disease control rate. And the response rate was excellent. So we're moving this to a first-line setting in the combination DGO5 study. Well, this is DESTINY-Gastric-05 study, which is a randomized phase 3 study. So hopefully we'll be seeing the results soon. So in DESTINY-Gastric-05, we're comparing T-DXd-based regimen with pembrolizumab and capecitabine to KEYNOTE-811, which is the pembro trastuzumab CAPOX regimen. Ultimately, what we need to see is the durability of the response, the toxicity profile, and the overall survival data. Because, of course, T-DXd is also available in later line setting. So the sequence will depend on various degrees of efficacy, but also toxicity. And of course, what brings T-DXd to the clinic is the off-target effect and bystander effect that it may impart on the HER2 low heterogeneous tumors that we see in first line, but also the side effect profile, because as you know, it's a oxaliplatin sparing regimen. So increasingly, as we're bringing immunotherapy in early stage perioperative setting, patients who are recurring and may have HER2 positive disease, so non-platinum containing regimen may be very appealing to them because it's, irinotecan type regimen. So I'm excited about all the options for patients. And what we're hoping to see is the future where the field is crowded and it allows many options, because if all of those options are approved in first line setting, the clinician and the physician can choose how to sequence them in best way. And then we just need to do additional studies to see if for example, next generation antibodies such as zanidatamab or even newer ADCs have other activities in later lines.
Next up, Scott Kopetz from the University of Texas MD Anderson Cancer Center presents progression-free and overall survival analyses from the BREAKWATER trial Cohort 3 of first-line encorafenib plus combined with FOLFIRI in patients with BRAF V600E mutant metastatic colorectal cancer.
The BREAKWATER study is a randomized phase 3 study that was looking at the FOLFOX chemotherapy backbone. After completion of the phase 3 study, there was what we call Cohort 3, which is a cohort of FOLFIRI backbone combined with encorafenib cetuximab versus a FOLFIRI-based control arm. So the study was designed to look as a primary response rate of primary outcome of response rate, but also key secondary of progression-free survival with exploratory analysis of overall survival. These were in previously untreated BRAF V600E mutated metastatic colorectal cancer patients that had not previously been treated with any therapies. Now, the response rate had been reported out previously, demonstrated a very nice improvement in response rate with the combination of encorafenib and cetuximab. But the data here was looking at the progression-free survival. What we saw with the data was that the progression-free survival was in the control arm was 8.3 months, and it improved up to 15.2 months with the experimental arm. So a really substantial increase in that progression-free survival. And this was at least numerically in a very similar range, if not numerically better than what we saw with the FOLFOX and encorafenib cetuximab, but demonstrated demonstrated the progression-free survival's improvements with this regimen. Now, overall survival is a secondary endpoint, and we have a early readout of about 18-month overall survival. And what we saw was that the median overall survival is not yet reached in the experimental arm, but it was 20 months in the control arm. The hazard ratio so far is right around 0.55 at this early look. So while this is not a powered endpoint, at least shows trends that are very similar to the doubling in median overall survival that we saw with the FOLFOX backbone.
Finally, Choong-Kun Lee from Yonsei University in Seoul, South Korea, explores the HERBOT trial evaluating first-line trastuzumab combined with nivolumab, gemcitabine, and cisplatin in HER2-positive biliary tract cancer, as well as discusses why HER2 testing matters in newly diagnosed biliary tract cancer.
So even the current standard of care, which is anti-PD-1, anti-PD-L1 combined with the gemcitabine plus cisplatin, the response rate is below 30%, and the progression-free is about 7 months, and the overall survival only slightly exceeding one year. So the HER2 overexpression or orbital amplification is identified in about 15% of the biliary tract cancer patients, and is known to be related to the worst prognosis. It became very exciting therapeutic target since there were many single-arm later-line trials. But the HER2-targeted strategies have never been evaluated in the first-line setting. So that's why I designed the HERBOT trial. The HERBOT trial is the multi-institutional, single-arm, investigator-initiated phase 1b/2 trial. The eligible patients included HER2-positive biliary tract cancer, metastatic, locally advanced, unresectable patients, which include gallbladder cancer, intrahepatic or extrahepatic cholangiocarcinoma. The HER2 positivity was centrally confirmed by the HER2 IHC 3 positive or 2 positive with EC positive. The patient received trastuzumab plus nivolumab every 3 weeks, plus gemcitabine plus cisplatin, and the gemcitabine plus cisplatin was continued until the cycle 9, followed by the trastuzumab plus nivolumab maintenance every 3 weeks. The primary endpoint was the recommended phase 2 dose for the phase 1b part, and investigator-assessed confirmed objective response rate for part 2, phase 2 part. So about total 40 patients were enrolled and analyzed. Most of the patients had the ECOG performance status 1, and about 70% of patients had the gallbladder cancer, and 2/3 of the patients had the HER2 IHC 3 positive. The study met its primary endpoint with the objective response rate of 55% and the disease control rate of 95%. Response was durable with the duration of response of 12.6 months. After the 17 months of the follow-up, the median PFS was 10.6 months, and the overall survival was not reached at the time of analysis. In terms of safety, the regimen was well tolerated without any unexpected safety findings. We, as an exploratory analysis, we did the pre-planned serial ctDNA analysis and the AI-powered whole slide image analysis. So this will represent also the AI-powered whole slide image analysis, which quantified the HER2-3 positive tumor cell proportion at the whole slide level, and also classify the immune phenotype based on the lymphocyte spatial distribution. Actually, the response rate was consistent regardless of the HER2 IHC status. But when we did the AI-powered whole slide image analysis, patients with the higher HER2-3 positive tumor cell proportion at the whole slide level, they had a greater response rate and numerically longer PFS. And also in terms of the immune phenotype, patients with the immune excluded phenotype had longer PFS compared to the immune deserved phenotype. So this kind of exploratory analysis, but it may help us to better understand the HER2 biology and its correlation with the tumor immune microenvironment in the biliary tract cancer, may refine the future of patient selection. So overall, the HERBOT is the first prospective study to demonstrate the feasibility and the encouraging activity of the HER2-targeted chemoimmunotherapy in the first-line setting of the HER2-positive biliary tract cancer. This trial research support for us to integrate the HER2-targeted strategies in the earlier treatment line, and also provide a strong rationale in the currently ongoing global phase 3 trial. We performed the HER2 immunohistochemistry for every newly diagnosed biliary cancer patients. And I know that it's not standard of care for any other centers, but I believe that HER2 testing at the very first, when they're diagnosed, especially for the patient with the metastatic or locally advanced unresectable, it will be the essential thing, as this kind of patient have had this HER2 positive biliary cancer patient has worse prognosis. So, and we have recently published a paper saying that this kind of HER2-positive biliary cancer patient definitely need anti-HER2 agent in their treatment journey. So I think moving this HER2-targeted strategy into the front line will give them more benefit. So I think it's definitely needed.
Thank you to our speakers and to you for listening to this podcast. If you enjoyed this podcast, please leave a review and subscribe on your favorite podcast app, including Apple, Podbean, and Spotify, so we can continue to deliver our expert-led content directly to you. Follow us on X at VJOncology and join in the conversation, and visit VJOncology.com for the latest updates and information.